nature. This is a very typical venous insufficiency wound. I saw one of these yesterday, except his was infected, so it was black and smelled horrid. This is very typical, distal 1/3 of the leg, typically on the medial side. They're usually irregular in shape, they're usually shallow. They usually don't have a lot of pain except in the case where they might be infected. The bases are usually pinkish red. These are associated with a lot of edema. A lot of times they have a dark area around them. This is called hemosiderin staining. Patients always want to know if this is going to go away. It doesn't go away. There are a lot of risk factors for these kinds of wounds, okay? Trauma in the area, like I was telling you about, someone who might have had several ankle sprains, or if they had a fracture of their tibia at some point in time on that side. If they have a history of a deep vein thrombosis, if they have a history of multiple pregnancies, especially if they gained a lot of weight with each pregnancy. If they're obese, if they have a clotting disorder, these tend to run in families, so if there's a family history of it. If they have an occupation where they stand, okay, so if they are somebody who stands at the post office all day long in that little cubicle, or is a cashier, or works on an assembly line. And the reason why all those things are important is you need to understand how the venous system works, okay? So the veins are a very low pressure system compared to the arteries, but they do have a little pressure behind them. So what happens is when I walk, my calf muscle squeezes, and when it squeezes, the blood is pushed up towards my heart, and then there's a vein that comes, there's a valve that comes together. As that blood goes up, then there's a valve that comes together. So if you think about all those things that we just talked about, okay, during pregnancy, there's tons of extra volume of fluid, right? So those valves can't get together. There's just too much fluid there. If you're standing and you're not ever walking, what happens is that blood goes down and it stays because your calf muscle doesn't get a chance to push it back up. So if you're just standing there checking groceries for 8 hours a day, or if you're cutting hair, or any of those kinds of occupations, if you're heavy and your veins get stretched just because of your size, so as long as you understand the mechanism of venous insufficiency, then you can understand why compression helps these folks, okay? So what do we do with them? Well, we need to clean the wound, then we need to debride it, then these wounds have a lot of drainage typically, okay? So you think about just your basic rules of science, okay? So if you have a lot of fluid, and the fluid needs to go somewhere, it's going to go to the place of least resistance, right? So if you've got a big hole in your leg, where do you think the fluid goes? It goes out the hole, because there's not any resistance to that. So we want to manage the edema. All right, how are we going to do that? We're going to clean basically the same way that we clean the burns, okay? We use Jetox, we use the surfactants, we use normal saline, everything at an appropriate PSI. One thing I didn't mention with the burns, and something that we can do a better job with, is warming these fluids to closer to body temperature so that they're not such a shock to the wound. Every time you take a wound dressing off and the temperature of that wound falls, healing is delayed until it can get back to the right microenvironment, okay? So when you put those dressings on, then the wound has to warm back up. So that's another reason why multi-day dressings are so great as compared with normal saline, where we were changing them, 3 and 4 times a day. Okay, there's some new wound cleansers out on the market. They're called Hypochlorous Acid. They go by the trade names of Bosch, Microcin, and there's some others. I'm not sure how I feel about these yet. We have Microcin. I've used it a little bit. You guys can read there what they say that it does, but basically it's a dilute Clorox. So you can just ruminate on that and make your own conclusions. Okay, so we've already talked about Santyl, and that it's the only debriding agent that is topical. So the other ways that we debride are forceps, scissors, scalpels, and curettes. Here's a picture of all those things. I like to use them all. Curette on the bottom left is probably my favorite. It's like a little ice cream scoop. So you put a little topical anesthetic on, and you can get a wound nice and clean with any of these items. There's also something available to physical therapists called ultrasonic debridement. There's a couple of, I think there's 3 different brands. I don't have one of these. I would love to have one when I get it back into full-time wound care practice. I bet you I'll get one. They're a little bit expensive, but they do a fabulous job of debriding, and there's no pain to the patient. You don't have to use even the topical pain relief measures. All right, so we haven't talked a ton about dressings except those dressings that are specific to patients with burns. But basically, what you should take away about dressings is there are several dressing categories. There are probably 10,000 wound dressings on the market now. But basically there are only about 6 or 7 categories of dressings. Okay, so gauze was the first thing we had. When I started practice, that was all we had. We either changed it once, twice, 3, or 4 times a day. That's basically the extent of it. How frequently were you going to do it? Then they came out with hydrocolloid dressings, which were the first multi-day dressings that we had. So if you can think about people that were in practice taking care of wounds many years ago and were used to seeing the wound from 1 to 4 times a day, for the rep to come in and talk to you about a product that you were going to put on and leave for 3 or 4 days was very, very scary to us. Because these were thick, brown colored dressings that you couldn't see through. So the very first ones we put on, we prayed over the dressing. We really wanted to look the next day, but it was just very, very scary. Hydrocolloids are not used a lot now for primary dressings, but they are still available, still around, we still have them. Then they came out with the alginates, which absorb more drainage than the hydrocolloids. We've already talked a little bit about the carboxymethyl cellulose dressings. Those are your Aquacels, your Aquacel AG. Those absorb even more drainage than the alginates. Then there's foams. So these are your exudate absorbers. These are very, very important to us in caring for VLUs or venous leg ulcers. The gauzes are the least expensive, but they don't work for everything. A lot of times it's just not enough. Typically this exudate absorber is going to go under some kind of a compression dressing if the patient has a venous leg ulcer. Okay? So it's important on these dressings to understand how they work and to understand if once the drainage is in the dressing, does it just wick it straight up or does it wick it across the dressing? Okay? Because you're going to leave this dressing on usually for a week. Medicare will pay us to change compression dressings 1 time a week. So if you put a dressing on a patient and the drainage comes up into the dressing and is wicked across the dressing, wound drainage is usually very caustic to intact skin. So if it wicks it across the dressing and then you leave that on for 7 days and you take that compression dressing off, a lot of times you will have a wound that's twice the size of the one that you put it on. So you need to understand these dressings, and the Aquacel dressings only wick vertically. They don't wick across. So those are a good thing to use. The foams are good because they apply additional compression in the area. Okay? So you put the foam on, you get compression locally, and then you put the compression dressing on, you get compression from the base of the toes all the way up to the knee. All right, so before you put the compression on, you have to do an ankle brachial index. And I have mentioned that a couple of times. I don't know if you guys know what that is or you don't know what it is. Very simple test, gives you some idea of whether or not the patient has good arterial flow. You don't want to put a compression dressing on if the patient doesn't have good flow. They will not be comfortable and they'll be calling you in just a few hours telling you to take it off. So that is standard of care to do the ABI before you put on the compression dressing. If the ABI is greater than 1, which is the case in a lot of our patients with diabetes, remember I told you that's because they lay down those calcium deposits in the arteries and you're not able to compress that artery all the way to get a good ABI measurement. You want to verify the healing potential with a transcutaneous oxygen measurement. Now, one of the places that Jeannie and I practice is in OU Physicians Building, and right next to us is the vascular physician. So they have the ability to do the TCOM measurement right there. And so what that gives you is that gives you a measurement of the oxygen in the tissues right there at the wound site. Okay, so that lets you know whether or not there is enough flow there that you're going to get healing. It's a non-invasive test. It takes about 40 minutes to do. I can do them. When I opened up my wound clinic several years ago, we have Hyperbarics in our clinic. So I was Hyperbarics certified. So when you get Hyperbarics certified, you're also certified to do TCOMs. It's a simple test, but can give you a lot of information. Okay, so what does your ABI mean? If you guys have, if you know what an ABI is, then you probably know what it means. But there are certain times when you get a very low reading that it's an immediate referral to a vascular specialist, okay? Those of us that do wound care a lot will probably tend to put compression dressings on at lower ABIs than somebody who doesn't do a lot of wound care, because we know how to wrap those compression dressings and where the patient is going to be in pain. So I might put a compression dressing on somebody that is at a 0.65 or a 0.7, whereas I would tell most of my younger staff, if it's not at 0.8 or above, please don't put on a compression dressing. Okay, you want to document all that super well. Do you guys know what vasopneumatic pumps are? Like a Flexi Touch or something like that? Let's see if I got a picture. Yes, I do. So it's another thing that physical therapists will use. It's a pump that has a sleeve that comes all the way from the base of their toes up to their groin, and you turn this pump on, and it's almost like a massage action. It has all these different chambers, and it'll blow up like at the toes, and then it'll blow up here, and then this one will release, and then it'll blow up here, and this one will release, and it moves the fluid back into circulation. The thing about these treatments is they need to be done anywhere from an hour to an hour and a half, at least once a day. It's kind of a cumbersome thing to set up. It's really frustrating when you forget to ask the patient to use the restroom before you set them up. You get them all set up in this thing, and then they tell you they got to go because all these patients are on a diuretic. So if it's a female patient, you're kind of stuck. If it's a guy, not quite as bad. There's just a lot of tricks that you use if you're using this modality. But it can be very effective. You can get these pumps for patients at home to use at home. We even have patients that are in compression dressings that pump over the compression dressings, which I think is kind of weird that they do it. It seems to still work. Again, you know, they need to time when they're taking their diuretic, even if they're using this modality at home. Multi-layer compression dressings are kind of the standard of care for someone who has a venous leg ulcer. There are, you can get these kits that have either 3 or 4 layers in the kit, and if you put them on correctly, which just takes a little bit of practice, they have the appropriate amount of compression to encourage the venous return. You can use whatever you would like to use underneath these compression dressings. We use a lot of zinc products to protect the peri-wound of these venous leg ulcers because they do have so much drainage, and because that drainage is so caustic. So products that are very similar to like Desitin, you know, just protects the skin from wetness. And then we put the exudate absorber on top of that, and then the compression dressing on top of that. And again, those are only changed about once a week. The dressings that come in a box with 4 different layers, those are better for your non-ambulatory patients. So if you think of the little old ladies that maybe are in a retirement center and they sit in a wheelchair up by the nurse's desk kind of all day long, and if you've ever seen them, they have that little puffy swelling on top of their feet. And you think about the fact that they've sat with their hip at 90 and their knee at 90 all day long, so you can see that that would kind of impede the venous return, right? So these Pro-4 bandages or any of the multi-layer bandages work pretty well with those patients because they have resting pressure. Okay, so once I put it on, it's the same pressure whether you're walking or you're not walking, just by the way the bandage is designed. As opposed to, let's see if I've got, okay, as opposed to an Unna boot, which is more of a rigid dressing. Do you guys know what an Unna boot is? It comes out of the package and it is moist. It almost looks like the casting material that you use. It has calamine and zinc in it. And you wrap it on, it's a pink dressing. You put that on over the top of your exudate absorber and your zinc product to protect the skin. And then we usually put a layer of Curlex on over that and then a layer of Coban on over that, just kind of hold everything together. And the Unna boot dressing, because it is stiff, as you walk around, it gives your calf muscle something to kind of push against. And so it doesn't have the same resting pressure as it has working pressure. So the Unna boot works better in somebody who walks around and moves a lot. And the Pro-4 bandages or the multi-layer bandages work better in the patients that are not as ambulatory. Okay? All right, so venous insufficiency doesn't typically get cured. There are some injections, foam injections and things like that that they're doing, but even with that, you typically have to wear some sort of compression forevermore. Either a compression hose or circ aids. These are compression hose. These have a nice zipper in them. The hardest thing about compression hose is getting them on. If you've ever put compression hose on, and I'm talking about compression hose, I'm not talking about TED hose, okay? Because TED hose are a piece of cake compared to these, all right? Because TED hose only have about 18 millimeters of mercury compression, the white anti-embolism stockings that people wear in the hospital. These are 40, okay? So if you think about the little old lady with arthritis trying to get these on, ridiculous, okay? But it's what they need because if you remember about wound healing, a scarred or healed area is only ever 80% as strong as it was before, okay? So if they don't keep the swelling out of that limb, that wound will break down in the exact same spot over and over. And that guy that I told you I saw yesterday, the third time we've seen him in 2 years because he will not wear his compression stockings. And it was this big, 10 by 6, and black and nasty. Okay, circ aids. These are a little bit easier for folks to put on than the compression stockings. Although they look like an octopus when you take them off, and so that can be kind of hard for patients, but they're just a neoprene sleeve, and they're adjustable, so if you decide that you're going to Red Lobster today, and you wake up tomorrow and you're way more swollen than you usually are, it is really tough to get your compression hose on, okay, because you're swollen. But you can put your circ aids on, and you can walk around, and as you walk through the day, your circ aid will work, and you can tighten it up, okay? Or, if you go to Pizza Hut at lunch, and you need to loosen your circ aid, then you can do that for the afternoon. So that's the beauty of these circ aid wraps, and they're not really all that much more expensive than the compression hose. Biggest thing about compression hose is people think if they buy them once, they're done. The lady that I saw yesterday, big old venous wound on her leg. I said, Deborah, how long have you had these compression hoses? Oh, about a year. Okay, so they're good for about 6 months. They need to buy 2 pair. You wash them, lay them flat to dry, have your patients take their bath or their shower in the evening, apply whatever moisturizing agent they like at night, let it soak in well, because all of those things that they want to put on their legs break down the elastic in the stockings. So you really don't want them to put those lotions and creams on and then pull their stockings on, because they won't even get 6 months out of them if they do, okay? Bad thing is most insurance companies won't cover these compression stockings unless there is a wound, okay? So just for prevention, patients and families are kind of on their own. Okay, elevation. This is another one of those things where when you're, just like when you're talking to a patient about nutrition, have your patient show you how they elevate, okay? Because if they sit in a recliner and their legs are below their heart, that's not the kind of elevation I'm talking about, okay? I want their trunk down and their feet up, which is kind of different, all right? But I don't want them in bed. I just want them to elevate a couple times a day. I just want to let gravity help us, okay? Exercise, I'm all about it. Works well with their compression on. These patients can get really motivated if you can get their buy-in the beginning. If you weigh these patients when they first come in and they're really, really swollen, and you can get them to buy into exercise and compression, they can see a pretty steady drop in their weight. Sometimes that'll get them a little bit more excited about what's happening. So that's one thing that we try to do. We don't want them to smoke. We want them to wear their compression garments. Don't cross their legs. That's just bad for their circulation. Elevate when they're sitting, and keep their feet and legs clean. Avoid trauma. One of the worst things in the world are dishwashers. Okay, little old ladies will have the dishwasher door open, and they'll either turn into it or they'll run into it. And if you think about the level of the dishwasher, it'll hit you right here where all you have is skin and bone. And those are exceedingly difficult for us to get well. We want them to watch their salt, inspect their leg every day, especially the area of the scar. Because if they're going to break down, it's going to be in that same area, and then it's going to be even harder for us to get it well the next time. All right, questions about venous leg ulcers? All right, arterial. Okay, this is what they look like. This is gangrene. This is a typical arterial ulcer. This is a referral to the limb salvage clinic. They need some kind of procedure to get some blood flow. Okay? They're typically on the lower leg, on the dorsal surface, mostly on the foot. And they're on the foot because there isn't a lot of soft tissue in the foot. Okay? It's basically just skin and tendons. Muscles are very well vascularized. Tendons, not so much. Okay? They can be on the malleolus. They can be on the tips of the toe joints. They can be on the lateral border of the foot. These folks hurt. They hurt especially when they're in bed. These are the folks that when therapy comes to get them up, they'll be in the bed like this with this affected leg hanging down. They're trying to get some kind of flow. They're trying to get gravity to pull some kind of blood flow down to that foot. Okay? The foot is cool. It's pale. You won't be able to find, when you try to find a dorsalis pedis or a posterior tibial, you won't be able to find one. A lot of times you won't see any hair growth on the leg. Now sometimes you see that anyway with guys because they've worn, jeans forever and tall socks. But you'll know the difference. I mean, the leg will be like super white. The skin will be shiny, dry, toenails will be thick, and the ulcers will be necrotic, and they won't have hardly any drainage as contrasted with the venous leg ulcer, which will typically have a ton of drainage. Just be kind of mummified like that. ABIs will be less than 0.5. If you have a patient laying in bed, you raise their leg, and then immediately just go white. Okay? When you put it down, it'll turn red. They'll tell you that they've had high blood pressure since they were very young. They've been a smoker. if they walk to the mailbox, their legs hurt. Those are the kinds of things that will come out in the history. These folks will have a long list of comorbidities. Well, I had bypass surgery in 2000, then I had stents in 2004 and 2006. They're on cholesterol-lowering drugs. They still smoke. They're diabetic. Dad had the same issue. And they might have any of those other issues as well. These are a challenge. So, check the pulses, check the ABI, check the TCOM, and then refer them on to a vascular surgeon or cardiologist. Yesterday, as I was finishing up the guy that gets the chemo and had the pressure ulcer, Bo Hawkins from our critical limb ischemia team called, "Can you see one more? I have a lady for me. I just did a procedure to revascularize her, and I'd like her seen before she goes back to EMIC." So that's what happens when you get involved with critical limb ischemia. There's not a lot of, it's not scheduled. You know, these patients come in, they have a limb that's at risk. They very quickly take them either to the cath lab or to the OR, restore the flow, and then they need to get the wound taken care of. Okay, I've told you how much I'd love to debride, but not on these folks, okay? When you debride, you make the requirements to keep that area alive, you've increased the requirement. And they don't have the blood flow to increase, all right? So don't start debriding on these folks. Now, the lady from Enid, if I had needed to debride on her, her flow is reestablished, and as long as her pulses are still good and that, then you can do that. But you want to be super duper careful with these folks. These are not the ones that you aggressively debride. A lot of times, you will see folks who have had one limb amputated, and now they have a wound maybe on the heel of the other leg or on the great toe of the other leg. They're a patient with diabetes who is going to dialysis 3 times a week. They're pretty sick. They're blind from the diabetes. These patients don't always go to the OR, and there's not always anything that can be done to restore the flow. So sometimes all you're trying to do is keep that leg attached so that they can do a pivot transfer on it, okay? We are not always trying to heal the wound. So in that case, where they have a black, stable ulcer, that's a time when we will use betadine. And all we're trying to do is make sure that that thing stays dry and that there's not any bacteria that can lead them to getting this second limb amputated. Because from a physical therapist standpoint, that person who has a leg to stand on is way more functional than that person that doesn't. So we've seen patients that have had a heel wound and had that for 5 years, and they were still able to stand and pivot and sit down and use their wheelchair. Okay, so we're not always going to heal it. All right, so your treatment is based on what you see clinically. We talked about ways that PTs have to increase the blood flow, a little heat in the groin, electrical stimulation. Sometimes we'll do things like, if the patient's blood pressure is where they can tolerate it, we'll take a little nitropase, put it around the wound, again, just trying to increase the flow there. There's a boot called a Rook Boot, which is a really nice boot that goes from the toes to the knee with the toes enclosed. And it's sheepskin on the inside, and it's built where the heel is what we call offloaded. We're not going to get any pressure on it. And those boots do a lot of things for our patients with arterial ulcers. They keep the limb warm. They protect it from that trauma of the dishwasher or even trauma of sheets on the foot. I've seen people who have gotten ulcers on the tips of their toes where they have been in the hospital and just the weight of the sheets put enough pressure on their toes that they got wounds on their toes. So Rook Boots can be great. These patients respond well to antimicrobial topicals, but again, you don't want to add any moisture. So do you remember the bottle of the silver powder that I showed you? That's a good choice. Or that's why we use the betadine that dries really quickly, okay? But you don't want to add a lot of moisture to these ones. We talked about electrical stim. Again, that's something that as PTs we can do to increase circulation in the area. Requires an E-stim machine, and then the treatments are about 45 minutes to an hour, anywhere from 3 to 7 times a week. Bed cradles, you guys know what bed cradles are? It's a, how do you explain a bed cradle? It's about this long, and it's metal, and it's shaped like this. And you put it in the bed, and their lower body is under it, and it just keeps the sheets up off of the patient. And you can make one out of like pillows positioned in different places on the bed, but honestly, just the weight of the sheets sometimes is too much for these patients that have this arterial compromise. The Rook Boot is a good heel protector. There are lots of other boots out there that will work for heel protection. We talked about how you might find the patient with their legs hanging down, or these are also the patients that will just sit at the side of the bed a lot when they're in the hospital. Again, they're trying to get gravity to pull that, and they do it subconsciously. They don't really realize what they're doing. We've used a lot of those shin guards that are the soft material, not the hard plastic, on some of our little old ladies that have had ulcerations on the front of their leg, just to keep them from bumping into things. It seems like, you know, if you've got a finger or a thumb that's cut, and it seems like every time you do anything, that's what you keep hitting. Well, that's the way with these little people. If they've got a wound on their anterior leg, that's what they keep bumping, is their anterior leg. Polysporin powder is another choice, as well as we talked about the silver powder, gentamicin drops, and then betadine. Those are all things that serve to keep these wounds dry, but kill bacteria that might be hanging around. Okay, these patients have to stop smoking. They have to stop. We talked about exercise, improving collateral circulation. So if they can walk, 5 or 10 feet, 6 or 7 times a day, that may be where you have to start. Okay. Medicare is now covering. You guys familiar with cardiac rehab programs for after bypass or after acute MI? They are now covering exercise programs for peripheral artery disease, which is kind of interesting. So that, to me, if Medicare is going to cover it, they have looked at it every which way. So it works. And if the patient has that dry gangrene, that mummified look that we saw of the hand, keep it dry. Okay, questions on arterial wounds? All right, negative pressure therapy. You guys know what negative pressure therapy is? Wound vacs, different, okay, love it. We can use it on all different kinds of wounds. Wounds have to be fairly clean. They used to say they had to be 80% clean. Those rules apply in the outpatient environment. They don't really apply in the inpatient environment because nobody's paying for it anyway. Everything you're getting is related to the patient's DRG. We can use negative pressure therapy in conjunction with like Apligraf or Oasis or some of the skin substitutes that are out. If you're using negative pressure therapy, you should see changes every time you change that dressing. It's a very expensive therapy, so if the wound is not changing, when you measure it, which we typically measure with our wound vacs, we typically measure the wound every time we change the dressing, but if it's not changing at least every week, then you need to back up and reevaluate what's going on. You either need to change the settings, or you need to add something topically, or the wound is infected, or the patient's not actually wearing the therapy. Something's not happening. Okay? Don't overpack these wounds. Our physician teams are kind of notorious for that. Of course, they're doing these with the patient's sleep. So when we change it a day or two after surgery, we pull out this piece of foam that's this big out of a wound that's this big. We're like, what? But we're doing it with the patient awake, so we don't tend to overpack as much as they do. You guys know about this. We kind of flip through this. Biological dressings. Oasis comes from the pig. It's an extracellular matrix that basically is used in a wound that has some depth, and it provides like a scaffold for the patient to grow tissue on. Okay, so when you put this in, it's not like some dressings. It's not like when the patient comes back in a week, you're not going to take it out. Okay, it goes in, it stays in. If it's having the desired effect when you look at the wound the next time, then likely once a week you'll just add another piece on top. Okay?
Is there ever like a bad reaction to those, like where the body rejects it and the wound gets worse and stuff like that?
This dressing is going to cause, this is one of the things that kind of pushes a chronic wound back into the inflammatory phase. We don't use these a lot with hospitalized patients because I work in a teaching hospital and we have a lot of residents. So the resident will come along and peek underneath and see this inflammatory response and believe that the wound is infected and take all of that off. And Oasis is very expensive, you know, $1,200 for a little sheet of Oasis. So I don't want the baby doctors messing with that. So we just save that for when we're managing them in the outpatient area where we don't have a lot of oversight. Does that answer your question? I've not had anybody have, I did have one guy that didn't do well with Oasis, but it was, his blood sugar was not in control, and we were trying whatever we could. We were just throwing everything at him, trying to save a foot. And I don't know if that was the reason why he didn't respond well to the Oasis. I kind of think it was, but I haven't ever had anybody else, just that one guy. You just irrigate gently at each dressing change, put another piece on top. Wound cultures, this is one of those things that best practice is to do a punch biopsy, but not everybody has the things you need to do a punch biopsy. Not everybody has the ability to give a patient a local so that you can do a punch biopsy. Cultures are okay if you adequately prep the area. I think where cultures get a bad name is when you take the wound dressing off, and I've seen some people culture the stuff that's on the dressing. That's not the appropriate way to do a culture. What you need to do is you need to irrigate the wound, okay, a lot. Get it clean. And then you take that, you guys all know the cultured things look like a little Q-tip. So you take that and you press on the wound until you get fluid from the wound on the Q-tip, okay? You don't really want to culture the top of the wound. Everything is colonized. My skin's colonized if you want to culture that. But you want to know what's causing that bad reaction in the wound. So you want to put enough pressure on that culture that you get the wound fluid on there. And then you'll get a much better result. Always let your lab know if you guys or the physician has put the patient on a broad spectrum antibiotic prior to the culture. Let your lab know that because that will affect the results somewhat. Hyperbarics. This is one of those things that was really, really popular 15 years ago or so. Medicare has really tightened down on reimbursement for hyperbarics. When I worked full-time in a wound clinic, when the reps came out and encouraged us to add hyperbarics, they'll basically tell you that 40% 40 to 50% of your patients can benefit from hyperbaric oxygen. What I found to be real was we put 15% of our patients in hyperbarics. I did see it save some limbs that I was really surprised at what it could do, but it's not nearly as useful as they will lead you to believe. This is a kind of, you guys know what this is? So this is taking oxygen and just driving it into the circulating plasma. And so that will, it takes about 2 hours to do the treatment. It's kind of like we were talking about with radiation. It's 5 days a week. They go at least 20 times. And then depending on the response of the wound, they may go even longer than that. But it does have, I have seen it do well with certain wounds. Okay. Just some other kind of, when I was working in the wound clinic, one of the physicians that I worked with was a pharmacist before he went to medical school. And so it was really great to see how he would use things kind of, not really off-label, but use things differently than some other teams that I have worked with. So clobetasol is a steroid, and with those venous wounds, they'll have kind of a real, kind of a woody, almost woody feel around the tissues when they've had this wound present for a really long time. And that steroid around there can help break up that woodiness a little bit. You never want to put a steroid in a wound because that will impede the wound healing. But we did see some great results with that cream on some really hard to heal venous wounds. So that was kind of fun. Cyclosporine or dexamethasone drops, or even now they've got it's like Restasis, I think. Those can decrease an inflammatory response. So remember I said a lot of times you have a wound that's chronic in nature and it's stuck in a particular phase. Well, you can get them stuck in the inflammatory phase the same as you can get them stuck in another phase. So if they're stuck in that inflammatory phase and they're not moving, sometimes these topical agents will help with that. Gentamicin cream works really great. It really helps topically, and it's really underused, and it's really, really cheap. So, you know, sometimes you think that because a drug is an older drug, that maybe there's something out that's better. This is one that we used a lot, again, based on the results of the culture. So the culture showed that the patient was sensitive to gentamicin. This cream worked really well. So it's just interesting. See, I'm going to make it. All right, so pressure injuries. New terminology. Was pressure ulcers. Before that, it was decubitus ulcers. Now they're called pressure injuries. Why are these pressure injuries important? Well, because if these are acquired in a hospital setting, these are considered a never event. So if one of your patients who is hospitalized has a stage 3 or a stage 4 pressure injury, you're not able to code that. Your coding team is not able to get any more money for taking care of that pressure injury. So it becomes really important if you guys are ever admitting a patient through the emergency department. Please, please, please turn them over and look, okay? Because most of these don't start in the hospital. We just don't do a very good job figuring out that they were there when the patient came in, depending on where they come from. Like for us, I work in a tertiary care medical center, okay? So we get patients from all over the state of Oklahoma, from Arkansas, Kansas, Texas. If they're coming from another setting and they are critically ill, what do you think the odds are that that thing was already started? Okay? But the patient is critically ill, so they don't want to turn them over. But it's really important that we do. Okay? We really don't want to take credit for any that aren't ours, because we will get some. Okay? And where we get them at our facility is a patient comes in with a neck injury, a bad neck injury, like they are almost don't make it, okay? And they can't take them right away to surgery to fix their neck. So you can't turn them if their C-spine is unstable. Well, they're going to get a pressure injury. but it might take the trauma team a day or two to get them stable before they can take it. And you know it only takes 2 hours to get a pressure injury. So these are horrible. So they need to be documented in the ER note, your admitting note, or your progress note. We need to know the location of it and the size of it. The physician or extender does not have to document the stage. You can leave that to the wound ostomy continence nurse or the therapy team, but you have to say where it is and that it was present on admission. And then we can take it from there. And if we call you and say it's there, please acknowledge that. Okay, this is another thing that happens, is people who are not as familiar with wound care will call a lot of things pressure injuries that aren't. So you must be able to discern between a diabetic foot ulcer, a skin tear, maceration, or IAD, incontinence-associated dermatitis, and then the arterial and venous leg ulcers. Okay? So don't call it pressure unless you know it's pressure. If it's not over a bony prominence, it's probably not pressure. Okay? So what are the risk factors? Obviously, pressure being number 1. Moisture. Are they continent? Friction. Have they been being slid up in bed? Or do they like to have the head of their bed up way high so they can breathe? And are they sliding down that all throughout the day? Are they hypotensive? So are they not perfusing things well? Have they been in the hospital a long time? And have they lost a lot of weight? So this is where you see them. You see them on the occiput. Those are extremely hard to find because most of us have hair there. See them on the sacrum. Ischial tuberosities, that's mostly if they're a patient with spinal cord injury. You see them on the heels, on the greater trochanter, on the lateral knee if you position the patient side-lying a lot, or on the malleolus. Stage 1, non-blanchable erythema of the skin. That's what that looks like. Stage 2, partial thickness. This is a lot of times confused with IAD, or skin tears, or burns, or abrasions. This is what a stage 2 looks like. Doesn't have to be too big or too deep to be a stage 2, does it? Stage 3. If there's any slough in it, it's automatically a stage 3 nowadays. And then stage 4 is full thickness, all the way down to the bone. And then you've got your unstageable. If you can't see the base of the wound, this is what it needs to be staged at as an unstageable. These are your deep tissue injuries. These are your patients that are down at home for maybe 18 hours before somebody finds them. When they come in, this is what it looks like. You can't really tell what it's going to be at that point in time, but you know it's not going to be good. So you initially call it a deep tissue, and then you can stage it as it declares itself. There's a new category now, pressure injuries due to medical devices. That's like tubes, drains, and cannulas. So if the patient gets a pressure ulcer on their nose or their ears from the oxygen cannula, that's how that would be termed. A lot of times they'll be rolled on a tube and lay on that. So that's kind of a new category that we're looking at. So facility acquired are typically on the sacrum. You would think that we don't have that problem in pediatrics, and we certainly don't have it to the extent that we do in adults, but on our kids that are on ECMO, that don't get moved too much, they can develop pressure injuries as well. Since we at OU Medicine are a level 1 trauma center, we have a lot of patients that are in various types of braces. CTOs, which is cervical thoracic orthosis, TLSOs, Jewetts, all kinds, hip spicas, all kinds of things like that. Very, very difficult to get patients in positions where they won't end up with some sort of a pressure injury if they're in one of these devices. Again, incontinence-associated dermatitis or excoriation from diarrhea, that will predispose your patient to a pressure injury, but initially, it's not a pressure injury, okay? So just be careful about how you're terming those things. Your nurses will know what is what. Okay.